going to be talking about naltrexone today. And we can go ahead and get started. I don't have any financial disclosures, unfortunately. For the treatment, well, I just wanted to start kind of with an overview, and obviously a lot of you probably have been tuning into these echo sessions frequently and kind of already know that medication assisted treatment is super important when we're talking about treating substance use disorders, and it's kind of the gold standard, in addition to, you know, counseling and behavioral therapy as well. So just kind of wanted to lay the groundwork. Some of this might be a little repetitive. Those who benefit from medication assisted therapy are, you know, the patients who get improved quality of life, are able to get back to their regular activities of daily living, et cetera. Providers who are providing that service to patients are able to see patients, you know, more frequently, and those who come back, et cetera. And then our community, as these patients get better and as they have their disease treated, then they can, you know, benefit their families and their communities in general. Here's just some data that you all have probably seen throughout Project Echo, showing that patients who use medications for medication assisted therapy, you know, do better than those who aren't using medications, et cetera. So one of our options for medication assisted treatment is to use naltrexone, but it's not always the first option that we think about when we are doing that. I wanted to take one sidebar real quick and just say, I see some chats that are coming through, and I've checked them a couple of times. It looks like most people are introducing themselves, but if any questions come up during, somebody can either come over audio and stop me real quick and ask, or we could address those at the end. So however you want to do it, I'm pretty flexible. But like I said, getting back to the presentation, naltrexone, I think we normally think of in alcohol use disorder and maybe not so much in opioid use disorder, but we're going to talk about its setting here for opioid use disorder as well. First, to start off with the formulations, we have two main formulations of naltrexone. So one is an intramuscular suspension, which I really like this formulation. I've seen some really good success with it with a couple of patients in our clinic, particularly for alcohol use disorder. And I'm interested at the end to ask Joyce if they've used naltrexone much or at all for some of our patients with opioid use disorder. I'm mostly over on the family medicine side and do interact with our addiction medicine patients some, but not all the time. Some interesting aspects of the intramuscular formulation. It's a very, so it's suspension. It's a very thick suspension. It can clog up in the syringe very easily, so it needs to be administered quickly. It's given in the gluteal muscle only. There are two different syringe sizes that come with it. So you get a 1.5 and a 2.5 inch syringe for administration. And there's also a separate syringe or needle that you use to reconstitute it. And it does need to be stored in the refrigerator, but you take it out, let it warm up to room temperature. And it needs to be administered by a healthcare professional. So unlike some of our other injections that patients can use, some of the new monoclonal antibodies, some diabetes injection medications that are more subcutaneous, this one needs to be administered in a healthcare provider's office. And then there's also the oral formulation as well. And we'll talk about some of the nuances between the two here as well when we get to the literature. So the mechanism of action, naltrexone is a competitive opioid antagonist. So when we're comparing that to some of our other options for medication-assisted therapy, we can see that methadone is a full agonist, opioid agonist, buprenorphine is a partial agonist, and then naltrexone is an antagonist. So the thought is that, it reduces cravings for opioids, just like it reduces cravings for alcohol. And that's why we use those in both of those settings. One of the benefits that you would get from naltrexone versus the others is it kind of eliminates abuse potential, because since we're antagonizing the opioid receptor, which can be kind of habit forming, since we're blocking that, there is no habit formation there. All right, I went too far. Okay, so when we're looking at naltrexone versus buprenorphine, I thought that it would be interesting to kind of discuss some of the data that is here. So there were a couple of studies, one for 12 weeks and one for 24 weeks. We'll focus on the 12 weeks first over here on this side. There were 50 in each arm and no significant difference in negative UDS, but there was a trend toward fewer days of heroin use with naltrexone, showing that naltrexone is a reasonable option. When we go to 24 weeks, it kind of depends on if we're looking at the intention to treat protocol or the per protocol analysis. And PP protocol is kind of redundant, so I probably need to get rid of protocol there. But basically, intention to treat means once they were randomized, whether or not they received naltrexone, they were still included in the end. So some people were told, hey, you are going to be given naltrexone, but they might not have ever gotten their first dose. And so when we look at those people, the patients that dropped out before they actually got the dose, buprenorphine was significantly better. But if you're looking at the patients that actually got the drugs, there was no significant difference between buprenorphine or naltrexone, showing that if you can actually get people to start naltrexone, then it works pretty well. The problem that we have is naltrexone, you have to be, because it's an antagonist, it can precipitate withdrawal from opioids, which can be super uncomfortable. And also, so in order to get that, the patients need to be off of any opioids for 7 to 10 days, which includes, buprenorphine, which can be really difficult for people, right? So if they have to stay away from substances and they don't have any medication treatment along with that, that can be difficult for them to get to their first dose of naltrexone. Okay, there was a Cochrane review that came out, but this is really old. It was from 2011, and it showed that oral naltrexone was no better than placebo for relapse. There was some significant reduction seen in patients who had been formerly incarcerated. Using oral naltrexone did reduce the return to prison rates in some of those patients. And so their conclusion was there was no evidence to use orally for opioid use disorder at that time, back in 2011. Since then, we've seen the extended release suspension used more frequently and studied more. And it appears that, again, if you can get the patients on the medication, it probably works pretty well. So again, like I mentioned before, for induction, if you're going to use short acting, which would be the tablets, they need to be off of opioids for 5 to 7 days. If you're going to do the long acting injection, they need to be off of opioids for 7 to 10 days so that you don't precipitate that withdrawal. And it's important that you confirm that with a urine drug test, or in some cases, they recommend a naloxone challenge. So you give the patient naloxone. If they're not having any withdrawal symptoms from that, then you know that they're good to go with the naltrexone. So for dosing, it's a little bit different opioid use or alcohol use disorder. With opioid use disorder, you start at 25 milligrams daily and increase to 50 if they don't have any withdrawal. For alcohol use disorder, you just start at that 50 milligrams. With maintenance, you can see there are a few different dosing strategies that you can use there, and I'm not going to go over every single one of those. One important thing to note is that if you're using the intramuscular long-acting injection, you don't have to start with the immediate release oral tablet. You can go straight to that monthly injection if that's what you choose to do and if that's what's best for patients. I just noticed I don't have my notes at the bottom of the screen, and I meant to talk about some of the newer evidence as well that I came across when I was kind of researching this a little last minute. I'm trying to think exactly what all I wanted to bring up. So one thing that they noticed that I thought was really interesting, and I didn't include it in the slides because I'd already submitted it to CME and didn't want to throw in any wrenches afterwards. But one study was looking at whether naltrexone or buprenorphine was better for patients that were homeless versus those that were not homeless or not housed. And that study actually found that you had lower relapse rates for homeless patients with long-acting injectable naltrexone than buprenorphine. And then the opposite was true for people who were housed. And I thought that that was a really interesting finding. So it was like a 50% for the patients that it was more successful in, it was like a 50% relapse rate. So in the homeless population, 50% for those with naltrexone and 70% relapse rate with buprenorphine. And you basically flip those if they are housed. So if somebody is housed, they have about a 50% with relapse rate with buprenorphine and a 70% relapse rate with naltrexone. I was not able to get full access to the article to see what the authors hypothesized, like what the reason would be for that, why they thought that might be the case. But I thought that that was a really interesting finding. And I think that was the main study that I wanted to. I'll check my notes after we're done and see what else I need to add in there. But if we're looking at how long it takes for these to work, naltrexone by mouth takes about an hour to peak, and intramuscularly takes about 2 hours. And then the duration there depends on the dosage if you're doing oral, and if you're looking at the IM, it lasts about 4 weeks. There are some inter-patient differences with that. Some people kind of get through that a little bit faster, or kind of metabolize their naltrexone faster. And I think that that's, you know, something that we don't have any objective measurements of, but you just need to check with your patient. Do they start to crave opioids or alcohol, whatever you're using it for, towards the end of those 4 weeks? And do you need to see about decreasing that dosing interval if needed? For those that are interested in the nerdy stuff about kinetics, it's metabolized by the liver, not by CYP enzymes. So you don't really have to worry about drug interactions too much. It's a other kind of pathway, and then it's eliminated in the urine as well. For surgery, this is where it can get a little bit tricky. So if somebody's undergoing major surgery where there's going to be a significant amount of pain, naltrexone will need to be held before they get that. Otherwise, you have to use really high doses of sedatives or pain medications. There's not a ton of information about that per se. The recommendation right now is if they're getting intramuscular long-acting naltrexone injections, holding for 30 days, which obviously puts them at increased risk of return to use in that time, which is not good. And then oral would be 72 hours before. You might also, if you have somebody that's on long-acting naltrexone, you might transition them to oral and then have them hold oral 72 hours before, if that's the route you want to go to. But there's not really great guidance on this so far. Another thing to keep in mind that I was kind of reading about and thinking about before I here recently, earlier today, actually, I was looking into some of this. If a patient uses naltrexone, they actually have their opioid receptors actually upregulate, so you have more opioid receptors. If they stop that, you have to be very cautious that they don't accidentally have an opioid overdose. So you need to monitor those patients really closely, especially if they're going in for surgery, or something like that, or having some sort of procedure. It's also something you need to counsel your patients on if they're taking naltrexone and then they return to use, especially that they don't go back to using the same amount of opioids that they might have been using before. As far as adverse reactions go with naltrexone, nausea, vomiting, diarrhea, headache, a lot of these are symptoms that you're going to get from the withdrawal, right? So we want to watch for those. Injection site reactions can be potentially severe if we're not injecting correctly. So if we inject subcutaneously instead of intramuscularly, that can lead to potentially even some necrosis of the tissue there. In some patients, you can see hematomas. So you've got to kind of watch out for those adverse reactions. And again, another precaution is if they do return to use, just the increased risk for overdose. And especially, so say somebody gets the long-acting formulation and then they decide they want to return to use, they're going to try to use a lot more, especially if it hasn't worn off. But then if their long-acting formulation wears off at week 5 or week 6, and they've been using still higher doses of opioids, that's a really increased risk for overdose. So you do want to make sure these patients have naloxone around also, which is a good idea for a lot of people anyway, even people who don't have any sort of use disorder. So some advantages of naltrexone: if you have somebody that concomitantly uses alcohol and opioids would be good for them. The monthly dosing is super nice. You don't need a data waiver to any sort of waiver to prescribe it or extra training. Not really risk of diversion because it's not habit forming. And it's good for patients who just don't want to use an agonist. You know, some patients still feel like they are treating their use disorder with another substance. And so in this case, or another habit forming substance, and in this case, you don't have that. One of the other results I wanted to talk about was a kind of a survey they did of patients with substance use disorder and their thoughts on naltrexone. A lot of them said that, like, whether they would be willing to use it or not. A lot of patients said they were pretty hesitant. They said a month of an injection felt like a year at the time that I was, presented that option. The patients that did go ahead and take naltrexone really liked it. They said they loved the monthly injection. They said it worked really well for them, and they would definitely, wanted to continue. And a lot of patients who said no to it later were asked, and they said, well, I wish I would have given that a try. I really like the flexibility of that monthly dosing, but it was just kind of unfamiliar and new to them. So hopefully, and it was unfamiliar and new to me before the first time that I gave this presentation too. So hopefully this will kind of demystify it for some people, and we can see that it's a reasonable option for some patients. So disadvantages: intolerable adverse effects for some people, poor adherence, especially with the oral version. But if you do the injectable, again, once a month, that's a lot better. You just have to make sure your patient's keeping up with that. And then the induction can be difficult based on the amount of time they have to be without opioids, and the risk for return to use at that time. So who's a good patient for naltrexone? Concomitant alcohol use, patients that don't have any access to agonists, so they have the time to kind of do that induction phase, the opioid-free induction phase. People that want to avoid agonists, people that have failed other therapies, people that have difficulty with adherence, but they can make it into the office one time a month to get their injection, and patients that have kind of a high risk of dependence. Here is a quick comparison of kind of our three main MAT agents, their dosage forms and precautions to kind of think about. So you all can find these slides on our ECHO website as well. I won't go through this full chart. And as a reminder, medication, just one piece of the pie, along with everything else that we need to, all those wraparound services that we need to provide for our patients. So there are my references. What questions do you all have? I see that there's some stuff in the chat, so let me see if any of that is actually questions or if we're okay. Nope, just references, which is great.
Thank you, Ryan. That was a lovely presentation and a fabulous overview of naltrexone. You had asked at the beginning about how much we're getting to use that in the addiction medicine side of the clinic. And while other people are ruminating on their questions they have for you from that presentation, I'm going to have Dr. Osborne introduce himself. Oh,
No.
That's not me.
No, I can just come this way.
There we go. Okay.
Hi, I'm Caleb. I'm one of the fellows here in the addiction medicine program.
Thank you.
Thank you.
And so I will just turn to the crowd behind me and say, how often do we get to use naltrexone for opioid use disorder? Unfortunately, never.
Yeah, for me, it's not been too often, but there is a patient that may be wanting to start it pretty soon, so that'll be my first experience with it.
Not as often as we would like to.
Yeah, because it's that difficult pace of induction, trying to get them to not have any kind of opiates for 7 to 10 days.
Yeah, and some of my experience with patients with alcohol use disorder is that they, I think that commitment to like a month-long injection really does seem hard for them. And they like the few that we've had that have used it, it works really well when they do use it, but getting them to come back, I've had, one patient that I can think of who struggled with alcohol use for a very long time, years and years and years. We got him on the injection. He did it for a few months, and then he's like, you know what? I don't think I need this injection anymore. And I said, do you think that might be because the injection's working? And he's like, well, I just want to try without it, so I'm not going to get it this month. And sure enough, we had, a return to use after that. And then afterwards, he was like, okay, yeah, I think we can continue getting this monthly injection at this point. But
Can I ask a question? So it's more of just an opinion. So when we use naltrexone a lot in inpatient facility here, so generally patients are detoxed off of opioids, so either with methadone or buprenorphine. We wait the 7 to 10 day period, initiate oral naltrexone and then Vivitrol. Can you all speak to the concern about hepatotoxicity in naltrexone? Like every now and then I'll get a patient who has borderline liver function tests, but I think the benefit of naltrexone is there, but some providers are hesitant in starting it because of their liver function.
Yeah, that's actually a really great question. I think some of that, so I've kind of looked into that a little bit, and it's really hard to say. I think from my reading of the literature, and I wish that I could cite something more concrete to you, but I think from my reading of the literature that I've looked at before is it's almost kind of, for some of it is kind of a chicken and the egg, like, are their liver function tests elevated because they used alcohol for quite a while and they're up there, or is it actually an issue with the naltrexone causing this hepatic damage? And I'm not really sure that we know for certain, but I do think that it's just one of those things that you have to consider kind of risks versus benefits, right? So like if it is going to help them, and then you just have to monitor it closely. I was looking at doing another drug information question for a provider the other day on fenofibrate and somebody with elevated liver enzymes, and it was kind of like a similar thing where we had to look, and it's like, a lot of the times with that one, as long as you catch it early and you notice that the liver enzymes are becoming even more elevated, then you got to stop it. But it's always comes back to that gray area of risk versus benefit, and is this the best option?
All right, yeah, thanks. That's kind of how I approach it. I've generally been going with the 5 times upper limit of normal. And if it's not, then I think you're right. The risk is much lower than the benefit. All right. Thanks, Ryan. Good to see you too.
Yeah, good to see you.
Any other comments or questions for Ryan? Cameron, I think you're muted. If you're talking to us, you're muted still.
Well, I have a question. I think that when you mentioned that if you take the naltrexone, does it down-regulate the receptors or up-regulate the receptors?
Now I'm muted. Well, I was muted. So it actually kind of up-regulates the receptors. I think probably the mechanism for that is they're not getting stimulated. So it's like how, your body's like, how do I get these stimulated? So you have more opioid receptors that come out trying to get stimulated.
So when we take the naltrexone off before the surgery, most likely the patient needs the higher dose in order to overcome the pain if it's upregulated. Is that correct?
So the way that I read it, and I could have read this incorrectly, but the way that I read it is now that we have more, if you, even with they were suggesting lower doses when you take them off so that they don't overdose, because that was the way that I read that particular resource.
Okay.
And I can link that one too if people want to read that a little bit more. That one was specifically from a continuing education for critical care providers that were managing patients that were on naltrexone, whether that was orally or the long acting. And I thought that was a very, very interesting read. Although I'm not on the inpatient side, I thought that was one question that I had last year when I was looking at this is, what do you do when you have somebody, in a car crash, a traumatic car crash that comes in on a long acting naltrexone or in similar circumstances to that. And that seems like just a really tricky situation to manage that will require just like a lot of close monitoring, multimodality. So, making sure that you're using for pain control, like Tylenol, potentially NSAIDs if they're appropriate for that, as well as potentially opioids, maybe nerve blocks, like basically throwing all kinds of different mechanisms at their pain as you can. So.
And also, I want to mention that the use of the naltrexone after a period of the not using any opioid agonist should be considered the half-life of that medication or that product that they were using, at least 3 or 4 half-life pass, in order to have less possibility of the withdrawal. We had patients that they were a slow metabolizer, and they after 10 days, even use of the naltrexone caused them the withdrawal symptoms. But those are rare that you see someone after 10 days, they still would have a withdrawal if they administer the naltrexone. And the best way to do the naloxone test, so that would be the best way to go.
Great, really lovely conversation, guys. Thank you. Because it's one we're all super curious about, because we don't get to use it, like I said, as much as we would like to in the setting of opioid use disorder. It seems to be much more accepted by our patients with alcohol use disorder and not our patients with alcohol use disorder and opioid use disorder, or just our patients with opioid use disorder. So thank you, Ryan, for that lovely presentation. And yes, the article you were just talking about, if you could send that to us in some fashion, that would be fantastic. Thank you. While Rochelle is getting ready for her case presentation, I'm going to have Joey unmute and introduce himself, please.
Hiya. We haven't met. Dr. Joey Tucciaroni. I'm a behavioral health consultant and postdoctoral fellow at Johnson City Family Medicine.
Fabulous. Thank you, Joey. It's good to have you with us.
Pleasure. Thank you.
Rochelle, do you have, do you just need to read us the case, or do you have it to share screen with?
I had just planned to read the case, if that's okay with you.
Totally fine.
Okay.
I was going to say too, I have the written one, but it may be a little better if it's up to you all how you want to do it, but I do have the written version here as well.
We can share screen and then also let Rochelle just read it, like give her oral presentation of it.
Sounds
That'd be
good.
great. Thank you, Melissa.
Thank you for sharing that. And also thank you all for having me. I'm excited to share this case. It's near and dear to my heart. So this patient is a 52-year-old cisgender male. He's currently unemployed and lives in government-funded housing. Through this program, he's required to attend therapy sessions at least once per month. Before entering this government program, he was street homeless and had been street homeless for several years. The patient was transferred to me by another psych extern at the day center. And before coming to the day center, the patient attended 2 to 3 different inpatient treatment programs. The longest he was sober before this current time was 5 years, but that was several years ago. The patient has misused alcohol since he was a teenager. And when I started seeing him, he was drinking about 1/5 to a gallon, so equal to about 16 to 30 drinks every time he did drink. And that was on average about a couple of times a week. But the frequency and quantity at which he drank alcohol depended on how much money he had. So despite efforts to allocate his money to other important utilities, he would spend it on alcohol. And by utilities, I mean like phone bill, new clothes, things like that. Alcohol use disorder was causing functional impairment for this patient, including loss of relationships, difficulties keeping a job, poor sleep, being unhoused, and incarceration for public intoxication, which he said happened more times than he could count. The patient started taking Vivitrol for alcohol use disorder in September. He received a voucher from the producers of Vivitrol to receive the drug free of charge. So since September, the drug just comes to the clinic and is administered by a nurse here. He has drank alcohol 1 time since starting Vivitrol. And this was precipitated by a neighbor coming over to his house and asking if he wanted to join him to hang out and drink. He said that he didn't feel any of the effects of the alcohol he drank and was a little bit sick the next day. More recently, though, the patient had a friend come over again to knock on his door and ask if he wanted to hang out and drink his favorite liquor. The patient said no and was pressured more by this friend. And despite the desire the patient had to hang out with his friend, he refused to engage in the situation. And the patient said that having a total absence of cravings made the situation easier to resist. So now the patient was recently diagnosed with PTSD, and we're working through treatment for PTSD, which looks a lot different given now that he's on Vivitrol and isn't experiencing cravings. So that's what we've been working on. And then I think my question is also on what Melissa is sharing, if you don't mind scrolling up. So given all of that, my question is, how can we advise our adult patients on building relationships without drugs and alcohol? And these can include romantic relationships or friendships. And if you guys have any questions about the case, I'm happy to answer them as well.
Wonderful, Rochelle. That was a fabulous case. I'm just going to do a real quick nutshell for everybody. 52-year-old male employed in subsidized governmental housing, which requires him to attend counseling. History of homelessness. It looks like from what you reported, he kind of does a binge style previously with his alcohol use, up to 30 standard drinks at a time when he did drink a couple of times a week. Recently started on Vivitrol and is doing really well on it. It's controlling his cravings really well. Had one time single episode return to use, found it to be really not that rewarding and hasn't had a return to use since, despite being presented with an opportunity. Diagnosis of PTSD recently made. It sounds like you guys are getting to focus on that. And the question is, because this is kind of where the return to use came from, building relationships that don't involve drugs or alcohol. So wonderful case. Let's dive in with our clarifying questions for Rochelle. You guys, who has any questions for her about any other details you'd like to know about this gentleman?
What's the approach y'all are taking for the trauma, the PTSD?
We've been doing cognitive processing therapy, which we started several weeks ago now, because sometimes things take a little bit longer. There's a lot to process.
Sure. It can be quite a process of just getting in there and creating some comfort around talking about these things. How's he taking to it?
Great. Yeah, really well. We've also pulled in his relationship with alcohol into treatment, which has worked out really well. And we've actually been focusing a lot on how he feels stigmatized, not only like related to the trauma he experienced, but also for misusing alcohol in the past, and from being unhoused in the past, just a lot of stigmatized identities. So
Sure.
We've been working on that a lot, and he really enjoys it.
Wonderful.
What kind of support system does he have?
He has two really good friends that he hangs out with most often. That is his primary support system.
And are they in recovery as well?
No, but they support his recovery a lot.
Okay.
Do they need appointments? Other clarifying questions for Rochelle?
Is he involved in any kind of community or club or some sort of fellowship where he associates with others?
He started going to AA more recently. Says he likes it. He likes it. Doesn't love it. He is getting more involved in church, but he's also sort of like lukewarm about that. So yeah, that's what I'm struggling with is finding him a community that he really takes to and is attracted to.
Is he active is he able to exercise or do any type of like fitness or group fitness?
I haven't proposed that. I can't really put my finger on why not. Maybe it's my own internal biases as to why he wouldn't be so into fitness, but that's a really good option. That's a really good option.
What, you mentioned that he is currently employed, correct?
He's unemployed.
Unemployed, okay, in my mind, I had employed, never mind then.
So when I say unemployed, he doesn't have a consistent job. He was interested in doing a job like on and off where they call him and he can go in, and he's built relationships around that, but in the past they've been built around like going out after work. And so he's not sure how to build those coworker relationships now, like without that.
Okay. Does he have interests? Like, have you probed like kind of what personal interests does he have? Any type of hobbies he's had in the past or ones he would like to undertake?
He really enjoys reading. He really enjoys playing games. Like he's really into D&D. So yeah.
That makes me think if he's really into D&D, there are some like online Discord groups that could be helpful for him if he's not ready to venture out into like real contact. I guess I could see him potentially being online.
Yeah, he does go to the library quite a bit, so I could like have him access the internet there, but you know, the library sometimes isn't like pop in with social interaction, so not sure. I don't know how to make that happen.
Is he on social media? Does he have a Facebook?
I don't know.
If he does, just if he happens to, there's a Johnson City Social Dungeons and Dragons Facebook group. And I want to say there's like some gaming spot that I drove by not too long ago. I need to double back and look into this, but it's like a gaming cafe. They might not serve alcohol there, but that would be an opportunity for him to connect with people. There used to be a place near Target, a game store there where they would have Magic the Gathering tournaments on Friday nights.
Yeah, Mulligan's is downtown.
Mulligan's?
Mulligan's, and so they do Friday Night Magic. They do, I think most days of the week, they've got some type of gaming that's open. Now the downside is I don't know if they're serving alcohol there now, but they do have plans to, I think, open up like a pub as part of the store there. But last time I was in there, that was just the gaming store.
Okay.
And then that's the only one I know of for sure. In the back of my mind, I'm kind of where you are. In the back of my mind, I think there are a couple others around, but that's the one that I know of for sure.
I have seen that place. I thought they served alcohol, but that's good to know that like you've been in there and it's like mostly a gaming place for right now. If that place by Target is still happening, that would definitely be a great option because he doesn't have transportation, but that's near where he lives.
Okay.
So like he walks all the way to me.
They closed up shop
Okay.
maybe a year or two ago, unfortunately.
Okay.
Yeah. But I mean, like, if we can find something comparable to that might be a great. I mean, it's just a sort of like social awkwardness that comes with being a gamer, right, in the first place, and then, but what but they recognize each other, and there's sort of they become this tight knit community, and they sort of nurture one another because they know what it feels like to be bullied or stigmatized or what have you, and just that shared interest, like, oh, you like this too, cool. It's like when, like 2 5-year-olds meet on the playground, like you're 5, I'm 5, we're best friends now, right? So there's sort of like hard and fast friendships that skip over all of that initial kind of shifty-eyed weirdness of trying to make friends as a grown-up. Might do him a lot of good. And instant social support.
even though a library, you usually think of it being very kind of quiet and studious. Is that a word? I just made it up. They actually have groups that get together. So there's like a calendar of events. They may have some gaming groups that get together. There may be some other things that he's interested in, especially since he likes to go to the library. And then just even the potential of, he likes to go to the library and he likes to read. Maybe he could volunteer in some capacity at the library. So kind of just that social engagement kind of a way. And he comes to the Johnson City Downtown Center. There's right across from that's Good Samaritan. That's another volunteer opportunity potentially in a way, like working in the thrift store down there or something. So yeah, just low hanging fruit ways to kind of get him to engage slowly and safely in a community that he's a little reticent maybe to jump into. I'm curious as well, like, because he has this history that you shared with us. And then in September, we started Vivitrol. What was that like, getting him started on the Vivitrol? What was that discussion like? How was that walk to get him from not to taking?
I wish I could speak to that, but the psych extern that transferred him to me was actually the muscles in that conversation. And so when he was transferred to me, I knew he already wanted to do it. So I just worked to find him a way to get it. And the day center was really supportive. So I'm sorry, I can't speak to that.
No, and actually, because that was one part of the question. The other part of the question, which you can, because you just told me that you're the one who took it the rest of the way home and scored the goal with it, because he's on a patient assistant program to get the medication covered. What did that look like navigating that?
I worked with the psychiatric nurse practitioner at the day center and then another nurse practitioner here. They sent in the referral. And I think it came back and they gave us some sort of estimate on how much it would be. And then he had to send in proof of income, which that was a little bit of a walk, given that he doesn't have access to a lot of his tax returns, didn't remember the logins to all that sort of stuff. And I can't remember how we worked around that. I think he had some very old pay stubs laying around that we also had sent in as proof of income, and that he didn't have an income at this time. And then they had just sent us information back, and the letter basically said, like, okay, great, we're gonna send you the medication, and then now we don't have to call or communicate with them. They just send it until the psychiatric nurse practitioner here says that he's no longer taking it. And then, like Ryan was mentioning, this patient and I, he hasn't expressed any concerns yet about not wanting to take his next injection. He's always been very much like on the ball with when he needs to schedule his next appointment and things like that. So that's good.
Yeah, it is good. That's excellent. And it's the company it's the manufacturer, right, that you went through. It wasn't some other, because there are sometimes like kind of clearinghouses that will help patients with meds. This is directly to the manufacturer of the Vivitrol. Okay, that's good to know, because a lot of us work with patients who don't have insurance. So hearing that you were successful in getting this expensive monthly injection covered for him by the company, that's some really good news. So
yeah,
thank you.
Yeah.
Guys, I can speak a little bit to because I've supervised this case for over, I get almost 2 years now, I guess. It was a long haul to get to the acceptance of this was what we were going to do. And a lot of that was definitely complicated by the comorbid PTSD symptoms. And we spent a lot of time building coping skills other than drinking, so that the idea of removing the alcohol and not having the alcohol as a coping skill available for a whole month didn't seem quite so daunting, because he had all these other coping skills that he now felt comfortable using. And then once we kind of got to that place of like, okay, like we have the coping skills, we could do this, then there was a bit of like a testing period of, well, I've got these coping skills, so I don't need the Vivitrol, and some return to use during those periods. And then I think in some ways, I think he was so hopeful about being able to address the trauma was in some ways what helped put us over and into his decision to change. And actually going for the Vivitrol was like, okay, this trauma is not going away. And the way I'm going to be most successful in addressing my trauma and being able to really commit to cognitive processing therapy is if I can stay sober for a long period of time. So it was a lot of motivational interviewing and a lot of kind of letting him come to the decision that this was what was really best for him and how he wanted to, the person he wants to be in the future. But yeah, it was a lot of work for sure on his part and the therapist's part. And then Rochelle has continued building that relationship.
That's awesome. It really is awesome because I was curious. Thank you, Meredith, for providing that, because it is a long walk. Sometimes it's a really long walk. Sometimes they've done that part of it before they get to you, and sometimes like you start step number one with the patient. So the fact that you guys have carried him through to this part, and he's getting the benefit of the trauma that fuels the fire that causes the drinking. You guys have quieted the fire so he can deal with what is making the fire happen. So it's really exciting. I can't wait to hear about him say, I don't know, in 6 months from now, I need to come back and give us an update, Rochelle, because it's a really awesome story to hear, like, you know, this has been successful. Our intention, like it's working, it works. Because sometimes we get lost. This week has been a week of being lost in the trenches of like, are we doing anything for anybody? So this story came at just the right time, Rochelle. Thank you. I don't know if anybody else on the call ever feels this way. So it's really great to hear that. So seriously, I'm putting you on the calendar 6 months. We're catching up and seeing how this guy's doing. Any other questions or comments for Rochelle and the amazing work she and her team have been doing?
I had a comment for the group, Miss Joyce. I've done a lot of work with Vivitrol patients. We have a grant that our patients are able to receive it for opiate use disorder, but we do struggle with the alcohol patients. But Vivitrol does have that patient assistance program. And our local rep in Memphis was excellent for a long time. He's doing something else now, unfortunately, but he was great at providing us samples and then helping the patients get set up on the patient assistance program so we could at least get them started, and then they could roll over to the assistance program to where it's provided by, I guess, by Vivitrol, where it's no cost to the patients. But I just kind of wanted to share that with the group. I don't know who the rep is in you guys' area, but ours was great for a long time. I don't know the new girl though, because I'm kind of in a different role now. So, but when I was a nurse, I worked with one of the nonprofits, and they had grant funding, like I said, for opiate use disorder, but we also use Vivitrol through our drug court and our mental health court programs that we have here, and our veterans court programs. And the courts actually provide the Vivitrol for those patients, which is lovely. And it's nice too, because we can actually get them successfully to it. Unfortunately, they've been some time incarcerated, but it gives them time enough to get to the Vivitrol, which is nice. So anyway, I just wanted to share that with you all.
No, thank you. All the information is great information, because knowing like how do we navigate this and get our patients what they need, and accepting they don't have insurance and so they can't have it. It's like we all know that's not a no. It's a how do we do it different way then.
And they had visited us at a previous facility that I worked at as a nurse. This particular Vivitrol rep, but his boss, and they have a whole system where you can enter the patient's information in there and kind of see where they fall if they're able to get the assistance. So they have a lot of resources if you utilize those people to help with, like I said, with samples and with getting through the patient assistance program. So anyway, that's my little tip.
No, that's excellent news. Good. Thank you so much for sharing, Suzanne. We all appreciate
absolutely.
Cool. Any other comments or questions before we all say goodbye for
I had a side note.
Yes.
So where I work, we do a lot of Vivitrol patients as well. And something that I kind of noticed over the course of time, just working with all of the patients in general, most of the patients I've seen that do well with Vivitrol are the ones who've already come in to do, we'll start off by doing the 5 to 7 day, the medical detox, and then they'll roll into what we have as the social detox program. So then that's like another 9 days of where they're kind of with other patients who are going through the same stage in the process. And so then a lot of those patients will roll into the 1 month long program that continues, where they develop all the coping skills and, learn techniques to go through the process, and they're with others who are going through the same scenario. I feel like those are the patients because they regularly go and see the doctor, they're who's in there and following up with them, and they're asking questions back and forth. And we early on introduced the concept of, Vivitrol. We mentioned, hey, have you heard of this? And a lot of them haven't. And so we start, hey, it's a once a month injection kind of thing, and get that kind of seed planted in their mind. So then when they come in for their, appointment when they meet with a doctor every few days, they'll, but hey, I'm thinking about that Vivitrol, can you tell me more about that? And so a lot of them, I mean, like 60% of them will want to do the Vivitrol shot afterwards. And a good, like 40% of those 60 that go on continue on and come in for their monthly shots. And then 6 or 7 months in, they no longer need those Vivitrol shots. And we also have that grant, a similar, kind of what was being said earlier. So we're lucky in that we don't have to worry a lot about convincing people financially, trying to be like, you have to go through all these obstacles to get it. So I guess there are resources available. It's just not, unfortunately, discussed as much. There are ways to get around things, but those options are out there. And I think a lot of people just don't realize that, if the patient falls within the certain boundaries, then they'll qualify for the funding through the grant. So that is pretty cool. And it's really awesome when we see them, because they're coming in outpatient at that point. And we even have like case managers that are assigned. So for people who have difficulties getting in, if transportation is a problem, to come get that once a month shot, once we make that connection, it's often like those small little details that prevent somebody from getting that treatment. And so it's not necessarily always just, oh, I'm scared of a shot, or, I just want to do it. Sometimes it's just literally getting there. And so when we figure that out, connect the puzzle pieces together, it's really magical to see the whole process go through and kind of play out in such a positive manner. But it's an awesome setup. Yeah, it's an awesome medication. So I'm all about it.
So it sounds like you guys are starting off inpatient with a number of these people, and then it's kind of this process through, and then it ends up in an outpatient piece. Yeah.
Yes.
That's nice you get to follow them through like that.
Yes, so that we can make sure that, they've been off that, whatever they've had in their system, flush it out for those 10 days, so that they're clear to start. And that way they're already around all these resources from, even prior to starting. So I think a lot of it's just that middle component of, am I ready for this kind of thing? So it's pretty much.
Yes, you are.
Yeah, you can do this. We got you.
Yeah, cool. Thank you so much for sharing that. That was really nice to hear about.
Yeah, no
Thank
problem.
you. Any other comments? Michael, it looked like maybe you had a thought you wanted to share. No, okay, all right. You look very wrapped there for a second. All right, good deal. Well, I just realized as I'm getting ready to close this out, this is our last session until 2022. So we will miss you. We want you to have the best, safest, healthiest holidays possible, because I want to see all your beautiful faces back up on the screen when we get back together in January. And you'll be getting emails about that, because I cannot tell you exactly what day in January, but maybe Melissa can.
I believe it's January 5th. Let me double check that just a second here.
Sounds right. I'm not trusting myself, but
yes, Wednesday, January 5th.
Right.
And it will be Dr. Tewell again.
Yay. I look forward to seeing all of you on January 5th. Take care and think about your cases. I know we've got some excellent cases. Thank you again, Michelle, for sharing that case. It was very exciting to hear about. Pallavi, maybe you've got one to share with us when we get back together in January. It sounds like you're around some really wonderful people doing really great things. We want to hear more about it. So, all right. Thank you, everyone.